Good morning. My name is Sarah Khatibzadeh, and I'm a third-year veterinary student at Cornell University. And today, I'd like to talk to you a bit about a topic that's near and dear to my heart and that I've been investigating over the past couple of years as part of a project for Dr. Donald Smith's veterinary history course, and that is the history of equine surgery. Now, rumor has it that when Cornell University founders Andrew Dixon White and Ezra Cornell were discussing how to build their new university, Cornell reminded White to include a veterinary college by saying, "Don't forget the horse doctor." Now, obviously, this is an urban legend. Ezra Cornell never actually said this. However, it serves to illustrate how important equine veterinarians were back when the United States was a mostly agricultural nation. Horses were a key source of labor on farms and a primary means of transportation. Now, nowadays, most horses are not pulling plows or taking people to the general store on Sunday. That being said, equine medicine, and in particular the equine surgery specialty, has been crucial in advancing horses in their new roles as both high-performance athletes and as beloved companion animals. So my project has multiple parts, but for the purpose of the speaking sample, I'm going to focus on the history of equine anesthesia. Now, equine anesthesia may not be directly related to the slicing and dicing that surgeons do. However, without quality anesthetic protocols, surgeons would not be able to do the complex procedures that they are able to do today. So when we think of equine anesthesia, we think of something that's shown in this picture right here. The horse is resting very comfortably in lateral recumbency with ample padding. It's hooked up to isoflurane and a multitude of monitors, and someone is dutifully standing next to them taking their vital signs every 5 minutes. But equine anesthesia wasn't always that pretty. In fact, at the turn of the 20th century, equine anesthesia basically did not exist. The primary means of restraint for surgical procedures were physical means, usually casting ropes, hopples, and when it was appropriate, a special operating table, which I'll show you in a minute. When additional drugs were needed, if the patient was particularly fractious or if it was a really challenging procedure that needed better visualization of the field, Sir Frederick Hobday, who is considered the founding father of veterinary anesthesiology, recommended either chloral hydrate or chloroform with a combination of local nerve blocks. Now, it's important to note that chloral hydrate and chloroform didn't produce true anesthesia like we think about it today. It mostly produced sort of a deep and uneven sedation that tended to vary a lot between patients and during the procedure itself. It's also important to note, too, how veterinarians viewed anesthesia in those days. If you open up a copy of Lum and Jones, they start talking about, smooth induction and smooth recovery and analgesia and amnesia. None of those were really talked about back then. In fact, Dr. Edward Merillat, who was a French veterinary surgeon and a leader in his field at the time, said, quote, "Anesthesia is a means of restraint and not an expedient to relieve pain." This diagram here shows how casting ropes were applied to lay the horse in either dorsal or lateral recumbency. Now, the men in this picture make it look very easy, but it was actually quite dangerous both for the humans and the horses. In fact, Merillat himself, who was an advocate for casting ropes, said that those ropes actually increased the risk of radial nerve paralysis, facial nerve paralysis, and fractures of the pelvis, olecranon, humerus, and tibia. If additional restraint was needed, you could use an operating table. But again, these operating tables are not like the ones we use today. What would happen was this. The horse would be made to stand parallel to the table, then straps would be placed around its abdomen and its chest, and when the horse was adequately buckled in, the table would be flipped 90 degrees, so now that the horse was in lateral recumbency. Now keep in mind that this horse was not sedated while any of this was being done, so again, a very dangerous procedure for the humans and for the horses. You'll also, interestingly, if you look at some of these photos from back then, you'll notice that the operating suites look nothing like the ones today. In this picture, you'll see a huge pile of shavings on the floor, and you'll notice that none of the surgeons are wearing caps or masks, or gloves for that matter. So for the first half of the 20th century, your go-tos for anesthesia were going to be your chloroform, your chloral hydrate, and your local nerve blocks. There were a few small discoveries after the 1920s, however. The first of which was barbiturates. Barbiturates had been used in human medicine for a short time, and so naturally veterinarians wanted to experiment with using them in horses. Now the good thing about barbiturates was they provide a very smooth and rapid induction into true anesthesia, which was great. The downside was they tended to produce very violent hallucinations upon recovery. So after the 1940s, they really weren't used as much in horses anymore. During the 1950s, two major discoveries were made, one of which was the use of succinylcholine, which is a paralytic. Now, succinylcholine was great for the surgeons because the horse would lie completely still. They could do whatever they needed to in an efficient manner and do the best job at the surgery that they could. However, succinylcholine just paralyzed the horse. It didn't provide analgesia, amnesia, or even any added sedation. In fact, it tended to make horses hypertensive during the surgeries, probably because they were in pain and couldn't express their pain. As such, there are reports of horses who, while having procedures done with succinylcholine, died of aortic rupture. Succinylcholine was used actually well into the 1970s. However, it's not considered a humane method of anesthesia today unless it is administered with a balanced anesthetic protocol. During the 1950s, halothane also began to be used in equine medicine. This was something, like barbiturates that human doctors were using in surgery, and so equine veterinarians thought that they could translate that into equine medicine. However, a lot of research still needed to be done because horses are particularly sensitive to halothane's effects on their cardiovascular and their respiratory systems. As such, halothane wasn't widely used until the 1970s. Now, the 1970s was a big, big decade for equine anesthesia. This is considered basically when modern anesthesia was founded. At this time, halothane was being regularly used for surgeries, and this was important because before then, surgeons were really limited as to the types of procedures that they could do safely. They were limited to their cryptorchid castrations, maybe some minor limb wound repairs, maybe some mammary tumor removals, maybe some dental extractions. But they weren't able to do the sort of advanced procedures that we think about today safely, such as colic surgery, major orthopedic surgery, etc. The thing about halothane, though, is that it didn't just come out of the blue. There were other things that had to happen in order for halothane to be able to be used safely. And one of those was the development of better anesthetic monitoring systems during the 1960s and 70s. The other thing that had to happen was equine ventilators had to be developed, because without proper ventilation, you're just putting anesthesia in, but there's no way to ensure that an adequate amount of oxygen is being delivered. And horses are particularly hard to ventilate because of the sheer weight of their body, which can compress a dependent lung, and the size of their gastrointestinal tract, which can press on their diaphragm and also decrease ventilation. So the first equine ventilators were actually developed in the 1950s, which were sort of crude. They were basically a wooden barrel with an old World War I gas mask attached. Luckily, during the 1960s, some better prototypes were developed in Denmark and Germany. And actually, the ventilators that we use today are based on those 1960s models. Another sort of interesting modification that happened during the 1970s was the use of ketamine and xylazine for induction. Dr. John Hubble, who is an anesthesiologist, has said that this discovery is probably one of the most important discoveries in equine medicine within the past century. The benefit to using ketamine and xylazine is that it produces a smooth and rapid induction into anesthesia, and it also provides 10 to 15 minutes of good quality anesthesia that allowed the surgeons to safely transport the patient from the induction stall onto the operating table and get all the monitors and the intubation hooked up before starting the surgery. So again, the 1970s, this is where the groundwork for modern anesthesia was laid down. However, things didn't stop in their tracks after the 1970s. In fact, there have been many, many advancements in equine anesthesia since then. One of them has been, again, increasing the quality of monitoring systems that we have. And this has been especially important, too, not just in being able to watch the individual patient during surgery, but informing anesthesiologists how to form better protocols based on how certain horses behave with a certain minimal alveolar concentration of halothane or isoflurane or what have you. So one of the most important discoveries was the use of intra-arterial blood gas monitoring in the late 1980s. This was key because now anesthesiologists could see, okay, how well are my patients actually being ventilated? Before they'd have to rely on, basically physical means like mucous membrane color and et cetera. Now they had more objective means to assess ventilation. Another interesting discovery that was actually made recently within the last decade was the use of intra-arterial blood pressure monitoring. And this, along with the intra-arterial blood gases, was important in sort of steering anesthesia in the direction that it's going today. And that is the use of more targeted, I won't say minimalistic, but protocols that tend to decrease or eliminate the use of inhalant anesthesia. The thing with horses is that even though anesthesia protocols are better today than they were 30 years ago, they're still exquisitely sensitive to the effects of isoflurane, sevoflurane, and the other inhalants. They tend to really depress cardiovascular function and respiratory function. This decreases perfusion to tissues during the operation and can contribute to postoperative myopathies. So one of the ways in which better monitoring has steered anesthetic protocols was in the development of what's called total intravenous anesthesia, or TIVA. This was developed in the last decade and basically followed on the heels of the development of intra-arterial blood pressure monitoring. Now, the good thing about total intravenous anesthesia is that there's absolutely no inhalant anesthetic used. Usually, patients are co-infused with a combination of an anesthetic like ketamine, a sedative like xylazine, and an analgesic. Now, the downside to TIVA is that it can only be used for operations that are 1 hour or less, because over time the drugs tend to accumulate in the horse's bloodstream and they can cause toxic effects. However, for those procedures which it can be used for, it's great because the horse's cardiovascular output is maintained, tissue perfusion is maintained, and the recovery and induction is as smooth as for procedures where a gas inhalant is used. Another sort of cool option that's come about and has actually become almost commonplace nowadays is the use of partial intravenous anesthesia. This is especially good for those procedures where TIVA just won't cut it because, a colic surgery is going to be 2 to 3 hours long. There's no way you can use TIVA for that. But with partial intravenous anesthesia, you're combining the infusion of the anesthetic and the sedative and the analgesic with the inhalant. And this allows you to dramatically reduce the amount of inhalant that you have to use in order to maintain quality anesthesia. And like TIVA, that allows you to have better cardiovascular output and better tissue perfusion during the procedure. Even better, some procedures don't have to be done with general anesthesia anymore. They can be done with what's called procedural sedation with local nerve blocks. This has become almost commonplace for some types of surgery. If you have to extract a cheek tooth or do a sinus flap, you do it standing. If you have to remove a granulosa cell tumor from a mare, you can do it standing with laparoscopy. Now, there are certain procedures that still have to be done with general anesthesia and the patient recumbent. However, even orthopedic surgeries can now be done standing. There was a recent study out of Newmarket in 2012 whereby I think 14 or 15 horses underwent fracture repairs of the distal limb successfully while standing, and the return to race time was better than horses that were done under general anesthesia. There also have been reports of chip fractures being removed off of the dorsal surface of the first phalanx, standing as well. Now, obviously, there need to be more case reports. There need to be more studies with standing orthopedic surgeries. However, these recent case reports do give hope that more orthopedic surgeries can be done standing in the future. The benefit to doing that, and it's actually a benefit for any standing surgery, is that one of the main risks to horses is actually after the procedure during recovery. Sometimes horses, while they're trying to rise and recover, can fracture the limb that has just been repaired if it's an orthopedic surgery, or they can fracture the contralateral limb. And so if you can do orthopedic surgery standing, or any surgery standing, if the horse never has to go down, it never has to get back up again, and that markedly reduces their risk of injury after the procedure. Another way that people have addressed the issue of recovery specifically for more invasive orthopedic procedures that can't be done standing is to use a recovery pool. The first pool like this was built in the 1980s at the University of Pennsylvania by Dr. Jacques Jenny, who is a famous orthopedic surgeon. The benefit to using pools like this is, first of all, the horse can come to its senses in a controlled environment where it doesn't have to bear weight or balance itself. This obviously decreases the risk of fracturing either the repaired limb or another limb. Also, though, it also increases the blood flow to muscles after the procedure, and it helps the horse ventilate itself in a more natural position. Both of these improve tissue perfusion, oxygenation, and therefore decrease the risk of postoperative myopathies. The horses probably have fun doing it too. I mean, who wouldn't want to go for a little swim after a painful procedure, right? These pools are not, I wouldn't say widespread nowadays, because they do require, a lot of money and a lot of time to actually construct and maintain. However, in 2006, Washington State University Veterinary College followed the University of Pennsylvania and built a pool of their own. And in this image here, you can see a horse happily recovering in the Washington State pool. So where is the future of equine anesthesia? Where is it going? I think the general trend is towards a less is more approach. Now, by less is more, I don't mean that we're going back to the old days of those casting ropes and the chloroform. What I mean is that we're using, again, more targeted anesthetic protocols that we've been able to develop based on better anesthetic monitoring systems and better ventilation. In this way, if we can work towards minimizing the types of procedures that need inhalant anesthesia and the amount of inhalant anesthesia that we have to use in procedures where it's necessary, we not only can still provide good quality anesthesia and allow the surgeon to do what they need to do, but we can also increase the safety of those procedures for the patients both during the procedure and after the procedure. So these are some of my references for this section. And for their insight, I'd like to thank at Cornell University, Dr. Campoy, Louis Campoy, Dr. Richard Hackett, and Dr. John Lutters. I'd also like to thank Dr. John Hubble at The Ohio State for his invaluable insight, and of course, Dr. Donald Smith, my veterinary history professor, for his continued advice and support during this project. If anyone has any questions, I'd be happy to answer them now.